Hi, and welcome to our presentation on investigating the predictive factors for diabetes diagnoses in the Pima Indian population. My name is Jonathan Zeman, and I'm here with Justin Mandel, Sujay Alluri, and Andres Lopez, and we're extremely excited to present to you our findings on these predictive factors.
Yeah, thank you, Jonathan. To start off, we're going over intro and research questions. For our introduction, we were looking through different data sets on Kaggle when we started ideating for this project, and we discovered the one about the Pima Indian population and noticed that the Pima Indians are disproportionately likely to have diabetes amongst different groups in the United States. And we essentially want to analyze the relationship between various things such as health factors, age, prior pregnancies, and a diabetes, and the resulting diabetes diagnosis or no non-diagnosis. Essentially, our research questions were trying to figure out which factors contribute most to diabetes. Could we predict with at least 70% certainty that somebody had diabetes based on our data? And then finally, do prior pregnancies affect the risk of a diabetes diagnosis among the Pima Indian women? So for the reason why our research questions are actually relevant is because we want to, conduct research that's relevant to the scientific community and society in the sense that if we can understand the factors that affect this population and create this disproportionately high likely, diabetes positive diagnosis, we could potentially help people like doctors implement better, stronger preventative actions to mitigate the chance of a diabetes diagnosis. Additionally, we wanted to ask a diverse set of questions to cater to the different factors that would potentially affect the diabetes diagnosis, as well as if we could predict if somebody had diabetes based off our data source. And finally, we wanted to place an emphasis on pregnancies after consulting with a couple of physicians who couldn't determine if that would be a factor. So we wanted to figure out, if that hasn't been thoroughly researched before, why don't we try researching it? So that's why we believe this might be our most important question as well. Then moving on to data source. Like I said before, we got the data set from Kaggle, and it has various variables such as that you can see here, such as age, pregnancies, health data, and diabetes in Pima Indians, amongst more. And then finally, this data set is actually originally from the National Institute of Diabetes and Digestive and Kidney Diseases, so that's why we think it's reasonable and a valid source. And then all the actual individual data inputs, the patients here are females that are at least 21 years old with Pima Indian heritage. And going on with the validity, the data set has almost 3,500 upvotes, so we deem it to be trustworthy based off this. And we aim to analyze the statistical significance between certain health factors and Pima Indians having the diabetes. And that's our overall goal for the project. And then going on to how we altered the data set, we replaced missing data for BMI, glucose levels, and blood pressure with the population average for the data that are missing those variables. However, in terms for skin thickness and insulin, we actually had to remove them because over 25% of the entries were missing, and we felt like we couldn't just put the population average, and because there was too much uncertainty including these values in our data analysis.
So for our first question, which is which factors contribute most to having diabetes, we first created box plots for all of the different factors, and we noticed that glucose, BMI, and age seem to have the largest correlation and the largest differences in median scores when you talk about someone with diabetes and someone without. So as you can see in figure 1, figure 2, figure 3, this shows glucose levels versus the outcome, BMI versus the outcome, and age versus the outcome, respectively. And one thing you should note is that we used a consistent color scheme throughout this presentation and our research, in that orange represents someone with diabetes and blue represents someone without. So as you can see, the average is higher in glucose levels, BMI, and age for all of them. And to verify this, we actually produced a correlation matrix, which shows on the bottom row the outcome and the correlation with each variable. And again, the glucose scored the highest, followed by BMI and then age.
So then we use these results to draw some more interesting conclusions. We first created a bar chart with age, which was the third most correlated factor. And then, so in the following graph, you can see that the dataset has more young people. And while each ascending age group has fewer total people, the graph shows that all the older age groups actually have a higher portion of people with diabetes compared to the whole population. And then we also created these two scatter plots seen in figure 6 and figure 7 to offer insight into trends and correlations. The first shows the relationship between glucose and age. And there's clearly this trend that people with diabetes tend to be older and have higher levels of glucose. And then we analyzed a scatter plot of glucose versus BMI. And likewise, there was a trend that people with diabetes tend to have a higher BMI and a higher glucose level. And then after building all of these visualizations and really gaining this like deep understanding of the data, we decided to go ahead and build a model to answer our second research question. And that question, just to reiterate, is can we accurately predict with at least 70% certainty that someone has diabetes based on the data? And so after trying several different models, we ultimately chose a k-nearest neighbor model because it yielded significantly better performance in initial trials. And at first, it was around 68% in predicting whether or not someone has diabetes. But after finding the optimal K value and testing out different combinations of which columns we were using, we're ultimately able to predict with 81.25% certainty, or predict accurately 81.25% of the time that someone has diabetes. And as you can see in this confusion matrix, we had 114 true negatives and 42 true positives with 27 false negatives and 9 false positives.
So our third research question was, do prior pregnancies affect the risk of a diabetes diagnosis in Pima Indian women? And to analyze this question, we decided to use a hypothesis test. So our null hypothesis is the risk of diabetes is the same for those with prior pregnancies and those without. And the alternative would be that the risk was not the same. And now we wanted to use a normal interval, but we decided that the data wasn't big enough. So we decided to use a t-interval and bootstrapping. And the reason for that was because we thought that the t-interval would be the best solution, but we wanted to use bootstrapping as a sanity check to make sure that our data was right, even though we thought that the data is normal considering it is population data. And our results were as follows. With 95% confidence intervals, we got the exact same interval for both of them, and the intervals overlapped, meaning that the means weren't separate enough to the point where they could theoretically, with 95% confidence, be different. So that we also conducted a hypothesis test using a p-value, and using a two-sided t-test, we determined that our p-value is not significant, so we cannot reject the null hypothesis. And we could not determine that the risk of diabetes for Pima Indian women who have been pregnant and Pima Indian women who have not been pregnant is different. This was slightly disappointing, but hopefully our next steps will be able to build on this conclusion and help us analyze the data further.
Lastly, regarding the limitations in future work, in terms of the limitations, one of our limitations is that our data set is only based in one population. And in the future, we would like to have a data set where we can analyze this to different populations, countries, and cities. Also, in terms of future work, we would like to better analyze the data by contacting hospitals and getting their data. For example, we could reach out to Duke Hospital or even hospitals in other locations so that we can have more data. And with more data, we can do a more in-depth analysis. We can also reach out to the author of the data set that we used and see if there is other variables that we should use. Also, if we have more columns in general and more data inputs, this would make our analysis better and we could have better predictions as well. Thank you so much for your time, and we hope that you enjoyed our presentation.